The very first hyperlink I've provided you on this page is to the Wakelet, and under the asthma column on the Wakelet, you'll see that the Asthma and Allergy Foundation of America has there is a link to one of their pages that is the description of why and how we use peak expiratory flow meters in the home setting. The video on YouTube that I've provided you with a link to, which is the second link, that is literally a child demonstrating the use of a peak flow meter. This is something that, according to your textbook and ATI, needs to be done at the same time every day. So maybe you do it when your child comes home from school. It needs to be that every single day. Maybe you do it when they first wake up. However we need to educate parents to do this, they need to do it every day. It is not something that you stop doing when you're in a state of wellness. It actually shows us over time what your state of wellness is measured at by the amount of flow that you can breathe out. And then we're able to see more clearly when that is not so great and also when it's really bad, so that you begin to know over time that when your number is at a certain level, you're in a danger zone and you need to do a little bit extra, which is shown on your home management action plan that you'll see on the next page. The doctor is going to give you management strategies for your green zones, which are your great days, your yellow zones, which is we're getting dangerous, and your red zones, which is whoa, it's bad. You probably need to try not to, or take yourself to the emergency room or call 911. And they also give you instructions on exactly how many inhalations of a rescue inhaler you need to have in each of those zones, how many inhalations of your controller medication you might need to have in each of those zones, and how often you should be doing both of those. So we use pulse oximetry as one of our vital signs measurements in the hospital setting and sometimes in outpatient. We're going to see likely a significant decrease in pulse oximetry in a chronically asthmatic child. It could even be normal if they're only having a mild exacerbation, but we still want to prevent that exacerbation or to treat it quickly, because every time they have an attack, whether it's mild, moderate, or severe, their lungs are going through a state of stress that causes some remodeling, and it becomes hyperreactive, which means each time they react to a trigger, the environment, exercise, by having an asthma attack, by developing the inflammation and the hyperinflation and the mucus, the next time they come in contact with that specific trigger, it could be much worse because their lungs are going to hyper react to those triggers. So we can do a chest x-ray, but like all other labs and diagnostics in pediatrics, if it's just going to show us what we already know is there, which is hyperinflation, we're probably not going to do it unless we're worried that there's a second sequelae occurring. We do pulmonary function tests, which is basically usually done as an outpatient, and they sit inside a little glass box. You have a little, like a clothespin on your nose to plug it up so you can't breathe through it. And then you have to blow into this weird little straw that's attached to a machine, and it measures all of your respiratory volumes, your tidal volumes, your expiratory volume, your inspiratory volume, all of that. We can also do allergy testing, which is really important. These kids very frequently need to find out what it is that's causing the majority of their asthma attacks. Unfortunately, living in Kern County, it could be just about everything. So when we talk about management of an asthmatic, we want to control or prevent the inflammation that is at the core of an asthma attack. If you meet a patient who is using their rescue inhaler every day, then obviously they have no control and are unable to prevent the inflammation. So we need to reevaluate the methods that they are using to treat themselves. They need a controller. They need leukotriene medications. They need something for mast cells, possibly. They need to be on an antihistamine. So a lot of your asthmatic patients you'll find don't even have a pulmonologist, and we should remedy that. We need to advise them to avoid triggers. Like I said, in Bakersfield, that's almost impossible. We have tumbleweeds everywhere. They're a massive allergic trigger. Stress is an allergic trigger. Sometimes cold and exercise and various different foods. Unfortunately, in this area that we live in, we have a year-round growth season as far as pollens and various different trees and flowers. There is not one season that we have where something is not growing. If you've ever sat back and wondered, why do we live in a place where there's a palm tree next to a pine tree next to a cactus? That should explain a lot to you. We literally have every type of plant growing in this environment. We're also completely enclosed, and we are filled with particulate matter in the air from the trucks, from the pollution that has nowhere to go, from dirt and dust. It's everywhere. So one of the things I tell parents to do with their child, or to teach them to do, is when they come home from school or they come in from playing and they're sweaty and their clothes are sticking to them, take those clothes off and put them in a different room from their bedroom. So maybe their clothes hamper needs to be somewhere else, because we don't want all of that pollen and dust and dander getting all over their room. So have a clothes hamper in the bathroom or in the laundry room. Once they've taken all their clothes off, they need to use a wet rag and just wipe themselves down. Do a quick wipe of their hair, wipe of their face, arms, legs, maybe chest and neck. And in that way, they're able to get off a lot of the dust, dander, and pollen that their own skin is holding on to after having been outside in our horrible air. And then they can put some clothes back on and go about their day. Just this simple act alone really helps a lot to decrease the amount of asthma attacks that a child whose triggers are environmental will go through. We're going to ask them to do peak expiratory flow rates every day at the same time and mark it down in a log. That way they know exactly where they're at and what medications they should be taking. And every patient has to go home with a home management action plan. All right, the next one's cystic fibrosis. It is an autosomal recessive disorder. It affects 30,000 people in the U.S. Used to be a death sentence. It's not so much anymore. The pathophysiology of this is that it is a dysfunction of the exocrine glands. So they get thick, grody, tenacious, just sticky secretions from their sweat glands, their GI tract, the pancreas, the respiratory tract. Their sweat glands are going to produce more chloride. A lot of parents realize that there is something different about their child when they have what we call a salty kiss. You kiss your child on the lips and it tastes salty. This is due to an electrolyte imbalance and often dehydration, but mostly the production of increased chloride. In the GI tract, it's going to be obstructed by really thick mucus and eosinophilic material. The pancreas, they lose their enzyme activity, so they have malabsorption of a lot of digestive nutrients. Their airways get plugged with mucus, and this leads to infections. If you look at page 1510 in your text, it's full of the pathophysiology and manifestations of cystic fibrosis. They get a lot of complications, a lot. Bacterial colonization, cor pulmonale, hemoptysis, pneumothorax, intussusception, intestinal obstructions, volvulus, rectal prolapses, diabetes, liver, the list goes on. Some of the signs and symptoms is that they have poor growth. These tend to be very small statured children. They have no little butt cheeks. It is just skin. They usually have a larger abdominal area and no backside, and really skinny arms and legs. They're just tiny. So they're going to undergo a sweat chloride test as one of the laboratory tests that they might have. We're going to always put them on pulse ox. They might have low saturations. They're going to have chest radiographs or x-rays that are going to reveal hyperinflation, thickening of the bronchial wall, likely atelectasis, and or infiltrates. Their pulmonary function tests are going to show that they don't really have a very high forced expiratory volume, and they also don't have very high vital capacities. Therapeutic management. We are trying with these patients to minimize the complications and prevent infection and maximize their growth. So we give them enzymes that help decrease the thickness of their sputum and their mucus. We give them bronchodilators and anti-inflammatories. We give them antibiotics that are aerosolized, so it gets into the lungs. We give them pancreatic enzymes and supplemental fat-soluble vitamins to promote digestion and absorption of all the nutrients that they need. These patients are very time intensive in the hospital. So with every meal, with every snack, they have to receive these oral pancreatic enzymes, and they take a lot of them. Other treatments that they're going to have is CPT with postural drainage. They often wear like these little vests that just shake them and shake them and shake them and kind of thump on them, and it helps to keep that mucus broken up. They're on high protein diets. They can also have lung transplants. Ask me to tell you a story about that. We're going to do education for the parents about performing CPT and giving the high calorie diet. And then we just need to kind of talk to the family about coping, because it's not easy being diagnosed with something that's going to affect you and your family your whole life. So we want to give them information about support groups and how to live as normally as possible.